We are live.
Very good evening and a warm welcome to iFocus Online Lecture 514, the sixth in Eye and Systemic Diseases. Today we have the very reputed Dr. Munna Bhende from Sankara Nethralaya, Chennai to speak to us on eye in diabetes and hypertension. She completed her MBBS from Kasturba Medical College, Bangalore, her MS Ophthalmology from Vinto Regional Ophthalmic Institute, Bangalore, Karnataka, went on to do her fellowship in vitreoretina surgery from Medical Research Foundation, Sankara Nethralaya in Chennai. She's currently the senior consultant and director at the same place, Sri Bhagwan Mahavir Vitreoretinal Service, Shankar Nethralaya, Chennai. She has over 3 decades of experience in managing both medical and surgical vitreoretinal disorders and has trained several ophthalmology residents and fellows in the same. She has over 120 peer review publications, one of which was also awarded the AIOS IJO Platinum Award. She is also the recipient of the AIOS Rema Mohan Award. Her special interests are in retinal imaging and inherited retinal disorders. She is the proud member of Macula Society, VRSI, INTRIS, and AIOS. We're really honored to have you here, ma'am. Over to you.
Thank you, Ashrita, and thank you, Santosh and Partho, for involving me in this program. And today I'll be speaking to you on the eye in diabetes and hypertension. Can you see my slides?
Yes, ma'am.
Okay, yeah. So by no means is this an all-inclusive talk. I'm sure there are a lot of things that are left out, but you probably have to read about them. And maybe if there is time at the end, I'll take a few questions. This schematic diagram is very interesting because it shows us that diabetes involves almost the entire part of the eye, starting from the ocular surface right up till the optic nerve. So the ocular conditions in diabetes mellitus could be either a direct association. What we best know is diabetic retinopathy. And you can have cataract, you can have disorders of the optic nerve, diabetic choroidopathy, and ocular motility disorders. It is a known risk factor for primary open-angle glaucoma, neovascular glaucoma, and the ocular ischemic syndrome. And there are various other conditions where diabetes could be a risk factor, and that is retinal vein occlusions, both central or branch vein occlusions, retinal arterial emboli, retinal artery occlusions, macular telangiectasia, recurrent corneal erosions, epithelial defects, and corneal ulcers. But it's also important to know that there are certain conditions which may mimic diabetic retinopathy and make you think that maybe the patient has diabetes. And these are retinal vein occlusions, hypertensive retinopathy itself, radiation retinopathy, the retinopathy associated with HIV and connective tissue disorders, and sometimes hemorrhagic forms or exudative forms of AMD. Coming to cataract and diabetes, there is a 2 to 5-fold higher incidence of cataracts and diabetes. And this could be either senile cataract, which is posterior subcapsular and enclerocortical, and snowflake cataract, which is exclusive for type 1 diabetes. And what is also interesting that you have a patient who has rapid glycemic control, and these patients can develop an irreversible increase in lens opacification, which is not seen in patients who have slow glycemic control. And the lens capsule or the basement membrane of the lens is thicker but more friable and prone to inadvertent tears or ruptures during cataract surgery in diabetics, which is why cataract surgery in a diabetic has to be proceeded with caution. And why do you develop cataract in diabetes? Basically because of oxidative stress, osmotic stress, and accumulation of sorbitol in the lens, where you have loss of fiber cell volume control and diabetic cataract formation. Now, what are the challenges during cataract surgery? I already said that the lens capsule is friable, but we also know that diabetics have poor mydriasis. There can be anterior capsular phimosis later on. The cortex, corticocapsular and cortical nuclear adhesions are very sticky in a diabetic, and these cause difficulty in hydrodissection and hydrodehydration. The nuclear cataracts are usually leathery, brown, and dense, and cause a problem during phacoemulsification. The eyes are also prone to develop postoperative inflammation, cystoid macular edema, as well as endophthalmitis. And all these have to be taken into account when you are taking care of the perioperative medications. And another caution is it is better to avoid multifocal IOLs, hydrophilic acrylic IOLs, and silicone IOLs in patients with diabetic retinopathy because they can cause problems in managing complications of diabetic retinopathy should they arise in future. Now, I just mentioned that diabetics are more prone to develop cystoid macular edema, but diabetics can also develop diabetic macular edema itself. And this is something that probably you are asked in the exams occasionally, how do you differentiate pure cystoid macular edema versus diabetic macular edema? Needless to say, the clinical features of diabetic macular edema like microaneurysms, hard exudates, and hemorrhages definitely indicate that it's not pure pseudophakic CME. And you would see these changes even on fluorescein angiogram. There are a few OCT differences. However, these are quite semantic. Probably I would suffice to say that clinical findings are more important than OCT findings, though you do see that neurosensory retinal detachment is more common in diabetics in pure cystoid macular edema compared to patients with diabetic macular. And this is a patient who had undergone laser photocoagulation for diabetic retinopathy. He underwent cataract surgery, and post-operatively, he came with cystoid macular edema. You see the cysts in the inner and the outer nuclear layer, a small amount of neurosensory detachment in both eyes. This patient was just managed with topical NSAIDs for a month, and you see how the edema has reduced. So these are cases which can be managed medically without the need for additional laser or injections. Cataract surgery is known to cause worsening of diabetic macular edema. Non-center involving diabetic macular edema can progress to center involving diabetic macular edema. Patients with no macular edema can develop macular edema after cataract surgery. Hence, it is important to evaluate all diabetics before they undergo cataract surgery to see if there's any evidence of diabetic retinopathy or macular edema. Manage them aggressively with perioperative NSAIDs if they do not have macular edema pre-existing. And if they have macular edema pre-existing, it's preferable to treat it before the patient undergoes cataract surgery. However, you may occasionally have a patient who develops cataract along with the treatment of macular edema. In such a situation, one may combine cataract surgery with an anti-VEGF or a steroid injection. However, it's also important to know that the role of prophylactic intravitreal steroids or anti-VEGFs in an eye with no macular edema or no diabetic retinopathy is highly questioned. Cataract surgery, apart from worsening diabetic macular edema, can cause diabetic retinopathy progression. And this can occur due to many factors like inadequate diabetes control, elevated levels of HbA1c, the initial severity of diabetic retinopathy itself. So if you have a patient with similar diabetic retinopathy in both eyes, post-cataract surgery, you may see the pseudophakic eye, the diabetic changes are worsening. Sometimes you may give insulin to rapidly bring down the blood sugar prior to cataract surgery. These patients can also show worsening of diabetic retinopathy. Associated high levels of LDL can also cause diabetic retinopathy progression. And also surgical complications like PC rent and vitreous loss, any postoperative inflammation can cause progression of diabetic retinopathy. Coming to endophthalmitis after cataract surgery, diabetes is an independent risk factor for endophthalmitis, where the risks are threefold increased. And diabetic patients account for about 14 to 20% of all patients who develop postoperative endophthalmitis after cataract surgery. And the major risk factors are males, patients who already have diabetic retinopathy, patients who have an associate history of hypertension, where you have to rapidly reduce the blood sugar to do cataract surgery, and patients who require insulin are at higher risk for developing endophthalmitis. And why does this occur? Because there is hyperglycemia, impaired immunity, impaired wound healing. And these eyes have a higher rate of conjunctival colonization with Staph aureus, enterococci, and certain streptococci, which increases the risk of infection. So in high-risk patients, it is probably good to have perioperative antibiotics as well. And endophthalmitis in an eye with existing diabetic retinopathy, the outcomes are generally poor, and there is rapid worsening of retinopathy in the eye with endophthalmitis. Coming to iris and pupillary abnormalities in diabetes, iris neovascularization is well known. Usually, these are severely ischemic eyes with proliferative diabetic retinopathy. The iris muscles and nerves can be involved in diabetes, so the pupillary dilatation is poor, and you may get pigment dispersion on the endothelium as well as iris atrophy. Coming to the ocular surface in diabetes, there is an increased risk of meibomian gland dysfunction, blepharitis, dry eye, superficial punctate keratitis, recurrent corneal erosions, persistent epithelial defects, and susceptibility to injury and ulcers. Hence, it's very important to take good care of the ocular surface in diabetes and avoid damage to the epithelium during surgery. Of course, this is more important in prolonged surgeries for diabetic retinal complications more than patients undergoing cataract surgery. And these changes are related to the duration of diabetes, greater HbA1c levels, and the severity of diabetic retinopathy. Why does it occur? Because there is combined trauma to the epithelial cells, reduced corneal sensation, and delayed wound healing. And it's important if these patients undergo any kind of surgery, you manage the dry eye aggressively during the perioperative period. This is a small schematic which tells us about dry eye syndrome in patients with diabetes mellitus. We have the role of chronic hypoglycemia, diabetic neuropathy, decreased level of insulin, microvasculopathy, and hyperosmotic disturbances, which cause lacrimal functional unit dysfunction, abnormal tear dynamics, and tear film dysfunction. In addition to elevated levels of AGE, inflammation, and various related proteins. In diabetics, there is impaired corneal wound healing because of changes in the basement membrane. There is diabetic corneal neuropathy, which can occur due to a variety of causes, and corneal endothelial dysfunction, where diabetes alters the corneal endothelium in both cell density and morphology. Glaucoma and diabetes also have a relationship, because diabetes gives rise to microvascular damage to the retina and optic nerve. It also changes the metabolism of the retinal ganglion cells, increasing the susceptibility to primary open-angle glaucoma. And there can be blockage of aqueous outflow by overexpression of extracellular matrix such as fibronectin by the trabecular meshwork cells and cellular proliferation. Uncontrolled diabetes with greater HbA1c levels can have significant higher IOPs. And of course, diabetics with severe ischemia and PDR can develop neovascular glaucoma. Coming to the optic nerve in diabetes, there are two abnormalities that we would see. A diabetic papillopathy, which is an acute disc edema with mild visual loss. It's due to a toxic effect of abnormal glucose metabolism on the optic nerve. It may be a mild and reversible form of AI1 and may be mistaken for papilledema because the visual disturbance is very minimal. It's important to know that this is a risk factor for progression of diabetic retinopathy. One may mistake the telangiectasis vessels on the disc for neovascularization, So it's important to verify that. This resolves spontaneously, requires good systemic control. The role of intravitreal steroids is controversial. Generally, one tends to just observe these patients. Whereas non-arthritic anterior ischemic optic neuropathy is a more serious problem where you have a disc at risk, small crowded disc, where the fellow eye may give you a clue. The patient usually presents with moderate visual loss while waking up, and this is because there is nocturnal hypotension. NaON occurs due to a transient anterior optic nerve hypoperfusion, as I mentioned, due to nocturnal hypertension, or there may be secondary local or systemic disturbances due to arteriosclerosis, vasospasm, hypertension, or various surgical or non-surgical hypotensive or vasoactive medications. And these are the differences between NaION and AION, mainly the age difference and also the ESR. Now, this is a gentleman, a middle-aged diabetic, who had blurring of vision in the right eye for about 2 years, presented with blurring of vision in the left eye. If you look in the right eye, there is a disc pallor. And if you look in the left eye, there are hemorrhages in the peripapillary region, and there is an inferior disc hyperemia and blurring. This was the fluorescein angiogram. As I mentioned earlier, the dilated capillaries of the disc can be easily mistaken for neovascularization. Here you see the dilated disc capillaries, and there are microaneurysms, and there is some amount of leakage in the retina. The corresponding B scan shows the disc edema as well as macular edema. These patients, though they could resolve spontaneously, may benefit with anti-VEGF injections where the disc edema as well as the macular edema can reverse. Coming to ocular movements in diabetes, extraocular motility disorders are well known. The commonest is probably the sixth cranial nerve involvement, where the patient will present you with a horizontal diplopia, but you can also get motility disorders involving the third or the fourth nerve. Coming to diabetic retinopathy, this is probably the best known and the most studied ocular complication of diabetes. In fact, when somebody says diabetes and DI, the only thing most of us think of is diabetic retinopathy. And there are a lot of complicated pathways which result in sight-threatening endpoints like proliferative diabetic retinopathy and diabetic macular edema. And probably the major driver of this is vascular endothelial growth factor. It's interesting to know that if you look at the retina, the vessels, these are the arteries, this is the glomerular capillary, and this is the retinal capillary. And we see that the changes in diabetic retinopathy very closely mimic changes in the glomerular capillaries as well. This is impairment of blood flow, leukocyte adhesion, increased vascular permeability. You can get impaired hemostasis. Proliferation is one thing that is not common between the retinal capillary and the glomerular capillary, but apoptosis can also occur in both. So suffice to say that since these are mimicked, very often you have the more severe the diabetic retinopathy, the patient also has renal involvement. And this is a normal retinal vessel. And here you see the pericytes sitting on the walls of the blood vessels. And in diabetic retinopathy, there is apoptosis, there is loss of pericytes, thereby disturbance of the blood-retinal barrier and leakage of blood and fluid. The pericyte loss gives rise to bulging of the vessel wall in the form of microaneurysms, and these can bleed, causing hemorrhages. Endothelial damage due to loss of pericytes can cause blood-retinal barrier disruption and leakage in the form of hard exudates. Then you can get leukostasis, which causes vascular occlusion, stimulus for new vessel formation. You can also get vasoconstriction, and you can get thrombus blocking the vessel where the vessel remains acellular with only a thickened basement membrane. Now, what are the risk factors for diabetic retinopathy? It's important to know that there are both modifiable and unmodifiable risk factors. The unmodifiable risk factors are the duration of disease, the type of diabetes, pregnancy, and puberty. And puberty is important for type 1 diabetes. There are proven modifiable risk factors, and it is basically common sense to say that hyperglycemia and hypertension are definitely modifiable. But certain conditions, there is a variable evidence, and these are dyslipidemia, nephropathy, anemia, smoking, high salt intake, and lithotripsy. So if you have a patient with diabetic retinopathy and diabetic macular edema, it's important to note each of these because these can finally affect the outcome of your treatment. Now, what are the findings? You can have no abnormalities, no clinical abnormalities in a diabetic patient. You may have just a few microaneurysms which signify mild non-proliferative diabetic retinopathy. You can have moderate non-proliferative diabetic retinopathy, which is microaneurysms with features like dot and blot hemorrhages, hard exudates, and corneal spots. Then you can have a severe non-proliferative diabetic retinopathy, where you have intraretinal hemorrhages, more than 20 in each quadrant, definite venous bleeding, intraretinal microvascular abnormalities, but no evidence of neovascularization. And proliferative diabetic retinopathy is the presence of neovascularization and other complications like traction or hemorrhage. As far as diabetic macular edema is concerned, we no longer use the word clinically significant macular edema. What we do describe is whether diabetic macular edema is present or absent, and whether it is involving the foveal center. Now, what are the other clinical findings? The important clinical findings you'll see in diabetic retinopathy. One is hard exudates, and they are a hallmark of diabetic macular edema. Why do they occur? They occur because of breakdown of the blood-retinal barrier, which allows leakage of serum proteins, lipids, and protein from the vessels. And as the fluid absorbs, the lipids get deposited in the Henle's nerve fiber layer. This is the outer plexiform layer. They are yellow, waxy, and usually surround a cluster of microaneurysms, like you see in this picture, which is why we usually call them cercinates of hard exudates. Now, the microaneurysms and the leakage can be picked up on fluorescein angiogram, but because of the filters we use, the hard exudates are not seen on FFA, they are seen only clinically. Intraretinal microvascular abnormalities are features that occur in response to ischemia. They are basically remodeled capillary beds without any proliferative changes. They are usually found at the border of the perfused and non-perfused retina. They do not leak on fluorescein angiogram. They can mimic new vessels. And if you look at these two slides, you'll see that the intraretinal microvascular abnormality, they do not cross vessels, they bridge vessels, whereas neovascularization crosses the surface. It hides the retinal vessel underneath and may be associated with hemorrhage and fibrosis. Now, neovascularization is the hallmark of proliferative diabetic retinopathy. The new vessels are typically seen within 45 degrees of the optic disc, and neovascularization of the disc is defined as new vessels at or within 1 disc diameter of the optic disc. And these can present with varying degrees of fibrosis, as you see these two images. Here there are bare vessels with fibrosis only in one area, whereas in the picture below, you see extensive amount of fibrosis with only a few bare vessels visible. High-risk proliferative diabetic retinopathy is an important definition because this is a definite indication for treatment. The large areas of new vessels or new vessels with any vitreous or pre-retinal hemorrhage, or large new vessels elsewhere associated with vitreous or pre-retinal hemorrhage. This is an important definition which you are likely to be asked in your exams as an indication for immediate treatment. Venous loops or bleedings. These are again a sign of a response to ischemia. They frequently occur adjacent to areas of non-perfusion. Here you see the fluorescein angiogram. You have areas of non-perfusion and the veins next to it is dilated and there is bleeding. They reflect increasing retinal ischemia and are a significant prediction for progression to proliferative diabetic retinopathy. Now, what I've shown you so far are very dramatic pictures of diabetic retinopathy, where imaging may just explain the findings, but it may not change much in terms of your initial impression. But occasionally you have patients like this. When you look at the fundus photograph, patient has normal vision, early cataract, and just see a few retinal hemorrhages and exudates. But if you do an OCT angiogram, you look at the picture on your left. This is a macular centered OCT angiogram. Centered at the macula, you see there is very good perfusion. A small hint of non-perfusion is here. But what is important is not diabetic. When you do your OCT angiography, you center the image on the optic disc and you see the areas of non-perfusion on the nasal side very prominently. It's important to know that a lot of changes, proliferative changes and ischemic changes in diabetes occur nasal to the optic disc. So it's very important to look at this area. And if you look at the B scan, there is no macular edema. This patient does not require any treatment, but has to be told that he is at risk for development of proliferative diabetic retinopathy and requires a very close follow-up. This is another patient. You see bilateral changes, more severe than the previous patient. There's a suspicion of new vessels on the disc. Now, this patient underwent a fundus fluorescein angiogram. The fluorescein angiogram shows the new vessels on the disc leaking profusely in the late phases. There are new vessels elsewhere. There is ischemia anterior to the new vessels. And if you look nasal to the optic disc, you see there are various small areas of early new vessel with capillary non-perfusion and ischemic vessels that stain because of the hypoxia. The OCT-B scan shows that there is no macular edema, but there is a thin membrane on the retinal surface. Whereas if you look at the other eye, the changes are not very severe. There is no neovascularization either at the disc or in the retina. There is no macular edema, but if you look in the mid-periphery, there is significant ischemia. So this patient, he requires panretinal photocoagulation in the right eye, but very close observation in the left eye because he's likely to develop proliferative changes soon. Now coming to center involving versus non-center involving diabetic macular edema, this is a new classification which is very important in the anti-VEGF era. What is non-center involving diabetic macular edema? Retinal thickening that does not involve the central 1 millimeter subfield zone. So you look at this patient, he has hard exudates temporal to the fovea. You look at the OCT, there are cysts in the macula, but not involving the center. Whereas if you look at the lower set of images, there is blurring of the macular details, a few hard exudates. You look at the OCT map showing a white area in the central subfield indicating there's macular edema. And if you look at the B scan, the whole foveal contour itself is reversed because of macular edema. Now, the importance of recognizing these two is center involving diabetic macula is definitely an indication for treatment, whereas anti-VEGF injections, whereas non-center involving macular edema can be observed, or if you see a few visible microaneurysms, you can treat them with laser photocoagulation. So these are 3 images of patients. This patient has mild diabetic macular edema where there are some hard exudates well away from the macular center. The patient has good vision. This does not require treatment. Here, the changes come under the category of moderate macular edema where the hard exudates are approaching but not involving the fovea. And here you have a case of severe macular edema, large number of hard exudates involving the foveal center with macular edema. And these are the guidelines which you would use while treating these patients. Basically, if you have macular edema involving the center with a drop in vision, it is an indication for immediate treatment. As far as proliferative diabetic retinopathy is concerned, pan-retinal photocoagulation remains the gold standard of treatment because especially in countries like ours where patient follow-up and finances are an issue, it provides a more permanent one-time treatment for diabetic retinopathy and reduces the risk of requiring surgery for complications of PDR. Laser delivery systems may vary. This is a patient who has had a fresh slit lamp delivery laser photocoagulation. Here is a photograph of a patient who has undergone laser photocoagulation a few months ago. You see now there are pigmented scars seen extending from just the arcades to the periphery. Laser photocoagulation is usually done in 3 sittings with the follow-up after 3 months. And you may consider adding an anti-VEGF injection if there is associated diabetic macular edema. India is probably not the ideal country to treat PDR with anti-VEGFs alone. Coming to surgery for diabetic retinopathy, there are certain traditional indications like non-clearing vitreous hemorrhage, tractional detachments involving the macula, or a combined traction rhegmatogenous detachment. However, there are certain newer indications that can cause a drop in vision, and these are vitromacular tractions, peripapillary tractions, dense premacular hemorrhages, and anterior hyaloid fibrovascular proliferation. I'm not going into the details of surgery. Coming to hypertension, which is the second part of my talk, hypertension can have direct effects on the eye in the form of hypertensive retinopathy, hypertensive choroidopathy, and optic neuropathy. Hypertension is known to worsen certain other diseases. These are established risks as far as the development and progression of diabetic retinopathy is concerned. It can cause retinal vein occlusions and retinal arterial microaneurysms. I'm sorry for the typo here. It should read as retinal arterial microaneurysm. And there may be a risk of other diseases such as glaucoma and age-related macular degeneration. Now, what happens in hypertensive retinopathy? There is an increased systolic blood pressure, which causes microcirculatory injury, remodeling, and associated endothelial dysfunction, which results in alterations in the arterioles, venules, and capillaries, the choroidal vessels, and the optic disc, and causes various forms of target organ damage in the eye, to the brain, the heart, and the kidney. And these can often occur hand in hand. The risk factors for development of hypertensive retinopathy are history of cardiovascular disease and carotid artery thickening, smoking, dyslipidemia, obesity, presence of diabetes, elevated creatinine levels, and microalbuminemia. The classification of hypertensive retinopathy, the first is none, the second is mild, where you have generalized arteriolar narrowing, focal arteriolar narrowing, nicking, and arterial wall opacification. Moderate retinopathy, where you have hemorrhages, microaneurysms, exudates, and malignant hypertension, when all these findings are combined with optic disc swelling. And this is a set of images from this very nice article in Nature Reviews Disease Primer, where the first 2 pictures show mild changes where you have focal or generalized arteriolar narrowing, moderate changes where you have cotton wool spots, retinal hemorrhages, hard exudates, though cotton wool spots are more permanent diabetes in hypertension and hard exudates are more common in diabetes. And in severe cases where there is disc edema. And you can also see hard exudates and neurosensory retinal detachments in association with the disc edema. And this patient also shows a intracerebral hemorrhage associated with malignant hypertension. Traditionally, when I was a student, we had to know the Keith-Wagner-Baker system of classification, but now it has changed. And now there is the Mitchell-Wong system, which combines some of the classifications to make it easier. Basically, the key pathological signs are retinal vascular remodeling and retinal arteriolar wall signs, which you see in the form of arteriolar narrowing, nicking, and opacification, the traditional silver wire or copper wire signs, or a combination of them. But when these lead to breakdown of the blood-retinal barrier, then you see certain microvascular signs like retinal hemorrhages, microaneurysms, and exudates. And the severe grade of malignant hypertension are the signs of moderate retinopathy along with optic disc edema. And here you have ischemia, raised intracranial pressure, hypertensive encephalopathy, along with bilateral optic disc swelling. This is something you should not miss. If you see a patient with disc edema, always check the blood pressure. These are the various stages. You have the vasoconstrictive phase, the sclerotic phase, the exudative phase, choroidopathy, and hypertensive optic neuropathy, aided by other features like inflammation, endothelial dysfunction, abnormal angiogenesis, and oxidative stress. What is more important is these are not sequential findings, and they can occur in any order. The vasoconstrictive phase is basically an immediate response to elevated blood pressure, seen typically in young patients. And this is seen as generalized or diffuse retinal arteriolar narrowing. However, with prolonged increase in blood pressure, the arteriolar walls begin to get opacified, they begin to get rigid, so you get arteriovenous nicking at the AV crossings, and you can get either generalized or focal narrowing. The opacification can present either as silver or copper ball or copper wire. And this occurs due to persistently elevated blood pressure. And it's called the sclerotic phase. And as I mentioned, the exudative phase is because of breakdown of the blood-retinal barrier, and you see changes in the form of exudates and hemorrhages. The hemorrhages in diabetics are usually dot and blot. They are deeper, whereas in hypertensives, the hemorrhages occur flame-shaped in the nerve fibrillary. And you can also get an entity called hypertensive choroidopathy, which is something that's not always recognized. And this is because of choroidal ischemia leading to high blood pressure can cause fibrinoid necrosis or the overlying retinal pigment epithelial and neural retina. We can see it in the acute phase as exudative retinal detachment, but we can also see them as Seigres streaks or Elschnig spots. Now, this is a young patient with patients with hypertensive retinopathy. If you look here, there is severe arteriolar narrowing. The normal 2:3 ratio of artery to vein is disturbed, and you have mainly cotton wool spots, a mild disc hyperemia, and a few flame-shaped retinal hemorrhages. This is another gentleman, and here you see these radiating streaks in the periphery, indicative of hypertensive choroidopathy, and these are Seigres streaks. This is a case of a young gentleman who presented with blurred vision in both eyes of 3 days duration. His visual acuity was 6.6 and 6 in both eyes. The right eye just had arteriolar narrowing and a few yellow spots if you look very carefully. The left eye had more obvious changes with a few cotton wool spots. You see some hard exudates in the papillomacular bundle area. And you look at his fluorescein angiogram. I'm sorry. look at his fluorescein angiogram, there are these few hyperfluorescent dots, which increase in the later phase. There are no clinically visible microaneurysms. This is the left eye of the patient. Again, you see these hyperfluorescent dots. In the absence of microaneurysms, his blood pressure was 250 by 170 and urine albumin was 3 plus, indicating that this is a severe form of hypertensive retinopathy, and this leakage is actually coming from the choroid. Another word for malignant hypertension is hypertensive optic neuropathy, which occurs in very severe hypertension. And this may reflect underlying hypertensive encephalopathy with raised intracranial pressure as well. This is another young patient who presented with blurring of vision in the left eye. He had been diagnosed to have a hypertension about a month ago. His blood pressure was 150/100 on irregular medications. You see the right fundus is normal except for a single hemorrhage here. But if you look in the left eye, he has soft exudates and hemorrhages tracking from a small tributary retinal vein towards the macula. There is subretinal fluid and hard exudates. And this patient has a tributary vein occlusion, the only risk factor being hypertension. So while one would manage his macular edema, manage the tributary vein occlusion, the most important is the hypertension has to be managed as well. Now, hypertensive retinopathy can coexist with problems in other systems. Retinal arterial narrowing has been associated with lacunar infarcts. And if you have more hemorrhagic hypertensive retinopathy, it is linked to cerebral hemorrhages. Hypertensive retinopathy and retinal arteriolar narrowing has been linked to dementia and cognitive impairment. In fact, retinal vascular narrowing is now sometimes used as a marker for Alzheimer's. And hypertensive retinopathy has been linked to coronary artery disease and heart failure. So while it by itself may not cause a visual disturbance, it definitely gives you a clue to possible life-threatening other complications. So to conclude, in diabetes and hypertension, the eye findings can be directly related to the disease. Most important, probably best known and studied are the retinal changes. The findings may be either direct associations or risk factors, possible associations and risk factors. There may be mimickers, which are important to recognize. But what is most important is in these systemic disorders, it is the treatment of the primary disease first and then its complications. So thank you for listening to me and be happy to take any questions or any discussions.
Thank you so much, ma'am. That was really a comprehensive, difficult task made to ease actually to bring in both diabetes and hypertension in ocular conditions. We do have a couple of questions. One of the patient images which you showed where the patient had not very evident diabetic changes, but on FFA there were hypoperfused areas. So how often should we call these patients for a follow-up and when should we intervene, ma'am? I think your volume is.
Yeah. Okay, I think we're talking about the first patient who had very mild diabetic retinopathy. I would call him every 3 months.
Okay.
But if he's going to have a cataract surgery in that eye because he came for an opinion for cataract, so then I would want to see him maybe a month after the cataract surgery, do a dilated fundus exam to find out if he's okay, and then follow him every 3 months.
Okay. What are there any common sites for neovascularization elsewhere? And is there a does neovascularization disc seem more riskier than neovascularization elsewhere? Is there any difference between the two?
Well, neovascularization of the disc tends to suggest a more generalized ischemia. whereas you can occasionally have just a small neovascular front in the periphery, in the mid periphery,
Okay.
and localized ischemia anterior to that. But now, previously, all these classifications were based on seven field photography. But
Hmm.
now we have wide angle imaging. We do know that you have peripheral diabetic retinopathy and central.
Hmm.
So you can have patients who are well perfused, but they can have just peripheral neovascularization. So it's important now to look at all organs.
Okay. And we know that in diabetes, retinal edema most commonly occurs at the macula. Is there any particular reason for this?
That's basically because of the arrangement of the nerve fiber layers. We know
Okay.
the Henle fiber layer, converges towards the fovea.
Hmm.
So that's the reason all and the microaneurysms, everything occurs in the posterior toe.
Okay.
So the fluid tends to leak in that area.
Yes, ma'am. So this is a question asked twice or thrice in our group. So diabetic studies are many, and when students go for examinations, it becomes a tedious task for them to remember everything. So is there anything that they have to remember for their theory and viva OCs?
I think a lot would depend on the age of the examiner and what they were. Uh, Probably I would say don't go into too much of detail,
Hmm.
but there are summaries of the various DRCR net studies,
Hmm. Hmm.
which will just give you a one line,
Hmm.
right? Like I mentioned, center involving, non-center involving. If vision is good, you need not treat, you can observe.
Hmm. Yeah.
So I would say just read a précis of the whole thing rather than I personally don't ask people those questions during exams, but yeah, I know that is something you need to know. But
Hmm.
probably a summary of the DRCR net protocols would be a good idea. But
Hmm.
if you have an examiner is a little older, are likely to ask you about the ETDRS.
Hmm.
So I think that is also important.
Okay. And so generally when patients have macular edema, we give anti-VEGF injection. At what point should you shift to a triamcinolone or a steroid injection?
Yeah, I didn't talk much about diabetic retinopathy because it was diabetes and the eye as a whole. So
Yes, ma'am.
yeah, but I'm okay with assisting. Just give me a second. I have to take this.
Sure, ma'am.
Yeah, sorry. When do we switch to a steroid?
Yes,
Yeah.
ma'am.
So I would say now we have a large number of anti-VEGF agents to choose from compared to when we had it earlier.
Hmm.
Your switch would depend on what you're looking at.
Hmm. Hmm.
Supposing you're looking at a total lack of response,
Okay.
one would want to probably change to another anti-VEGF agent. Like
Okay.
say, supposing you're starting with bevacizumab, you may want to go to ranibizumab or aflibercept
Hmm.
because we know they have less of local side effects
Yeah.
like raised intraocular pressure, which is a real thing.
Hmm. Hmm.
Of course, you have to balance it with the cost, but when I'm talking to you now, I'm not considering cost as a factor. I'm looking at effect in the eye.
Yeah.
So one would definitely look at agents which are known to have a good drying effect, which have
Hmm.
less local complications and
Okay.
may last longer.
Hmm.
And if you have a systemic risk, like the patient has recently had a cardiac event or a stroke or something, then you may want to switch to a steroid.
Hmm.
If you think the patient may not want to come back that often, then you would ask for a longer acting anti-VEGF, like you have the newer drugs,
Hmm.
which act for a longer duration,
Hmm.
or you can give a steroid,
Okay.
but you have to watch for pressure rise.
Okay. Yes, ma'am. So, there are some conditions where there is asymmetric progression of diabetic retinopathy, like one eye is PDR and the other eye seems to present as mild PDR. So, what is the cause of this? Is there any conditions which decrease the progression of diabetic retinopathy, or why does it asymmetry occur?
So mild asymmetry can occur even after cataract surgery.
Okay.
And PDR, mild and severe, I wouldn't worry too much about. But if I'm seeing PDR, neovascularization of the iris, and no diabetic retinopathy or a very mild non-proliferative, then I will ask for a carotid Doppler.
Okay.
Because then I'd be looking for a block, an
Okay.
ocular ischemia.
Hmm.
I would also be looking at myopia, patients with very high myopia, unilateral high myopia. You can have no retinopathy in that eye.
Okay.
Or a patient with optic atrophy, a patient with already a vascular occlusion, whether it's not hypoxic, but the whole thing is ischemic. Or you have a patient with retinitis pigmentosa or a spontaneous reattached retina, then they are less likely to have, because the requirement is less of blood supply in those eyes. So there's no stimulus for proliferation.
Okay.
So
These are the conditions where they have an asymmetric diabetes.
glaucoma.
Yeah, glaucoma. And what is hypertensive induced optic neuropathy? Like only are there condition like does only the optic nerve get affected in optic, hypertensive changes? Does this happen without?
NAION is also a risk factor. Hypertension is a risk factor for non-arthritic optic neuropathy as well, in
Okay.
addition to diabetes.
Okay.
So that is one of the causes. But usually if you have malignant hypertension, then it occurs with other retinopathy signs as well.
Okay. And in pregnancy induced hypertension, what are the ocular manifestations that we see?
Well, I think what people are really looking at in pregnancy-induced hypertension is the presence of dyskidema and exudative RD, which is an indication for termination of pregnancy. And
Oh.
that is generally what we are looking at when we are asked to see the fundus.
Mm-hmm.
Now, there are other eye signs in like CSR, they also occur. But I think what you're looking at in a serious form is the presence of dyskidema and exudative retinal detachment.
Is there any role of immediate management, or we just allow them to control the BP and then thereafter manage the eye condition?
This is related to the eye condition. Hypertensive retinopathy itself is not managed separately.
Okay.
Diabetic retinopathy is a separate entity, whereas hypertensive retinopathy by itself is, you do not manage it. It's usually the complications like a vascular occlusion, a retinal artery macroaneurysm, or something that you need to manage.
Okay. Yes, ma'am. That is all the questions that we got on YouTube and the group. It was wonderful having you here. A large topic really made crisp to pointers, and all the important points were covered extremely well, ma'am. Thank you so much. We are glad to have you here on iFocus, ma'am.
Thank you. My
And
pleasure.
thank you so much, ma'am. So our iFocus offline is happening this time, and from August 10th to 17th at New Delhi. We would love to have you all here. The seats are limited to only uh, 300, out of which only 75 are remaining now, and hope you come soon, attend it. It's going to be a session of great fun, an extravaganza of both academic and a lot of interactions with stalwarts of different places from different various centers giving their lectures. Also, there are various prizes to win, various competitions to participate in. It's going to be great fun. So I would like to take this opportunity to invite you all for iFocus 2025, the National Postgraduate Education Program in Ophthalmology. Coming to the end of this iFocus session, the next session will be on 25th June on eye and hematological and cardiovascular diseases by Dr. Vishal Raval. Thank you so much, ma'am. Here we come to an end of today's session. Good night, everyone.